case today.
Well, thanks, Robbie. That's quite the intro. Hopefully the case lives up now. It's good to see everybody who was here, whatever day of the week I was here. But yeah, currently in Florida on vacation, just hanging out. I'm really happy to be back here after a couple of years away.
Amazing. All right. So we'll engage you all in the chat in a little bit. I think Andrew's cases always keep me on the edge of my seat. So I'll definitely need your help. So stay tuned for some active participation and learning. All right, Andrew, kick it off, please.
Sure. And as the last case, the aliquots are going to be kind of in different boxes and presented in kind of real world time. So I'll try and guide whoever's scribing kind of to the right boxes. Okay, so the first aliquot is going to be HPI info and some past medical and vitals. So this is a 66-year-old man. He had emphysema, not on home oxygen, cirrhosis secondary to HCV, hepatitis C, a liver transplant in the past on cyclosporin and mycophenolate mofetil. He also had a history of biliary strictures requiring stenting, a resected lung adenocarcinoma, and CKD4. He presented with 12 days of progressive dyspnea and chest pain. He had chronic intermittent sputum production, unchanged from his baseline, no hemoptysis, no fevers or rigors, no GI symptoms, no lower extremity swelling, and no orthopnea. At initial presentation in the ER, he had a max temp of 100.3, heart rate of 93, blood pressure of 132/73, and an oxygen saturation of 85% on room air. This improved to 95% on 3 liters. And I'll put this aliquot in the chat as well.
All right, I can already tell we're going to have to move very far along in this case to make a diagnostic certainty because of how complex it is. So I'll be very quick. I think it's helpful to break down these cases into, that is my doggy. It's helpful to break down these cases into the background and the foreground. And I think by doing that, it'll become clear what that means. The background here is all the organs are down. The lungs are down with COPD. The liver is down, both in terms of cirrhosis, but has been replaced by a new liver whose status we don't quite know yet in terms of how well it's working. But it is also with that move brought down the immune system. Lungs down, maybe liver's down, or replaced by a better working liver. But the liver is compromised in some sense by the immune system and by the fact that there's impaired biliary drainage. And again, we don't know how bad those things are, but the kidneys are also down. So we got lung, question liver, kidneys are down, and the immune system is down. That's the background. What's the foreground? The foreground is more fun to play around with here because it goes to show you how much progress you can make with the following concerns. Chest pain. Vast majority of chest pain that shows up to the emergency room is discharged with a benign diagnosis. What happens when somebody has chest pain and shortness of breath? The presence of shortness of breath markedly reduces the probability of a benign diagnosis of chest pain. What does hypoxemia do to shortness of what does hypoxemia do to shortness of breath? It confirms a sinister cause and localizes an aspect of the disease to the pulmonary alveolar parenchyma. You watch that? Chest pain? Who knows? Could be GERD, could be MSK. Dyspnea? Probably not going to walk out with a benign diagnosis, still possible. Certainly things like anxiety and reactive airways disease can get discharged simply. But then when you have hypoxemia, gosh, not only have you made tremendous progress in terms of understanding the morbidity of the patient, you know exactly where the disease lives. It lives either in the alveolus or the blood vessel. But be careful, just because the lungs are involved does not mean that other organs are also involved as well. The most common example of this is when somebody has cardiac failure causing the lungs to be involved, filled with fluid, but the heart's the real problem. So here we have a complex background, but we know that there is something wrong with the lungs. We don't know whether that is referred from somewhere else, like the pleura, the heart, the kidney with nephrogenic pulmonary edema, but we know the lungs are involved in some way, shape, or form. It's not just that the lungs are involved, period. They're involved in an inflammatory way. And that inflammatory phenotype is gauged by the fever. So this is fever plus pulmonary disease, plus minus other organs that refer to the lung in a very complex patient with all the organs down, but most importantly, the immune system is down. So now the question becomes, what is this febrile pulmonary syndrome, plus minus other organ syndromes? But let's take a second to say, is there anything else we need to think about as causes of fever in the first hour of evaluating this patient apart from infection? And a quick checklist for that is the 3 H's. The H for way too hot, hyperthyroidism. No meds, no reason to suspect that I can tell so far, but if we see that he's in atrial fibrillation, we might have to change our minds. Hematologic causes. Most commonly transfusion reactions. If the patient's febrile in the context of a transfusion, that heme category skyrockets. And here there's actually a couple of things to track in terms of heme based on the patient's medication list, but those are too rare to invoke now. And the final H is hyperthermia from medications, usually serotonin syndrome, NMS, so on and so forth. No hits for that. So for now, this is an infectious pulmonary syndrome in an immunocompromised host with many organs down. And I think you probably want to get a sense of 2 things. What is the nature of the pulmonary involvement? And is there a subclinical systemic imprint? Is the liver involved? Are the kidneys involved? Are the muscles involved to help you make progress? I said I would be brief, but that was like 15 minutes later. Thank you for the incredibly rich aliquot, Andrew, and I'll hand you the mic to take us forward.
Yeah, of course. I think some questions will be answered in this next aliquot. So for the next aliquots, we're going to skip over exam and just go to some objective findings that are seen on initial presentation. So a chest x-ray showed emphysematous changes, a small right-sided pleural effusion, and prominent interstitial markings bilaterally. His labs showed a white count of 6.2, hemoglobin of 7.8, that was normocytic. I'll say his baseline was around 8.5, so similar. A platelet count of 258. He had a procalcitonin level of 3.32 and a NT-proBNP of 11,860. His baseline pro-BNP was 5,300. And he had hyperbilirubinemia with a total bili of 3.7, a direct bili of 3.2, and he had AKI with a creatinine of 2.93. And I'll put this in the chat too.
Well, I think you definitively answered the question of other organs being involved. And the answer is the heart involved? Absolutely. I think that BNP elevation, especially, well, actually, sorry, what's his baseline again, Andrew? Can you say that again?
It was a couple thousand lower. It was
I'm
50,
sorry.
yeah,
I missed
yeah,
that.
50, or the baseline was lower. So the baseline was 5,300 and the new one was almost 12,000.
All right, gotcha. Okay. Yeah, so the doubling of more than doubling of the BNP tells you that there's some cardiac dimension involved. And I think that a BNP in isolation is probably not enough, though it's a decent case. But when you layer that on with the chest x-ray findings of a right-sided pleural effusion and a chest x-ray infiltrate, I think you make a decent case for the heart being involved. And so now the question is the heart causing the lung issue, or is there a separate underlying lung issue? And I think the only way to know for sure is to diurese the patient and watch what happens. And the question is, well, what's going on with the liver and what's going on with the kidney? And I think anytime the heart is involved, it's very easy to invoke plumbing and congestion as the cause of the liver and the kidney abnormalities. The kidney abnormalities can be easily explained away by that finding, but the problem is that the liver findings are a little bit unusual. That's because the vast majority of patients with congestive hepatopathy have more of an indirect hyperbilirubinemia than they have a direct hyperbilirubinemia. So it would be curious to know if you want to bend the rules a little bit and accept that, and it's totally okay. But again, diuresis would be very informative. It's also still an open question what his baseline bilirubin is because he has that stricture. So I don't know, Andrew, if that is something that you can shed light on now, or if you want to keep it a mystery for a little while. It's up to you.
His bilis were, I'll say, mildly to moderately up from his baseline. I don't have the exact values, but somewhere in that realm.
No problem at all. So, I think you have to be careful. You could simplify this to a cardiac problem, but the assumptions you'd be making and missing an underlying lung, liver, and kidney disease. And how do we tease this out in real life? We watch what happens with diuresis unless there's an emergency. to prioritize another cause in those organs. So if the patient were requiring intubation from their lungs, you'd probably say, wait, hold on, I don't want to make that assumption. If the patient has significant liver issues, you probably would stop and say, I don't want to make that assumption. And the same is for the kidney. So before we simplify this problem, I think there is one issue in the liver that is an emergency, which is that you have cholestasis, direct hyperbilirubinemia, and a fever. That reflexively should mean cholangitis until proven otherwise. So I think that we haven't quite proven otherwise yet because we're invoking a heart problem. And heart problems are rarely febrile in nature. Most people have regular old non-inflammatory heart disease. So the question is this person having cholangitis and decompensated heart failure from an easily explainable decompensated heart failure from the fact that his COPD is pretty bad? And you can come up with a million reasons why he would easily have decompensated heart failure. So is this cholangitis unmasking decompensated heart failure? Or is this a febrile cardiac syndrome causing congestive hepatopathy? Or is it something else? So it's hard to tease that out, but I think that if you're saying this is a febrile cardiac disease, you have to worry about the itises: endocarditis, myocarditis, and pericarditis. There are reasons for each of those things. He is immunosuppressed, could easily get endocarditis. He is on a couple of medications that can cause myocarditis, and pericardial disease is easily linked to malignancy. So all those hypotheses are fair game. Fever plus new heart failure also should make you check a TSH to make sure you're not dealing with a manifestation of thyroid storm. Easily ruled out. So that's where I'm at, Andrew. I think I'd be really curious to see. Oh, I didn't comment on the procal. The procal gives us a little bit more impetus that the infection is bacterial in nature. But remember, the data on procal is plus minus to make that inference and more on de-escalation of antibiotics. But it's hard not to, when you're getting momentum for a bacterial infection, it's not hard, not intuitively to use that to support that fact. So we have a systemic disease: lungs, kidney, heart, and liver. It could all be connected by the plumbing. The wrench in that hypothesis is twofold. The direct bili is high, and the patient is febrile. Fever is unusual in heart disease unless you have the itises. So maybe this patient has the itises, or they have an extra cardiac infection. Yeah, that's all I got. Andrew, you want to hand it back, tell us more? I'll hand you the mic, tell us more.
Yeah, I've given you a lot of variables to play with. That's a great discussion. More info to come on kind of all these organs, but it may be a bit until you get some of your final answers, just the way that he kind of transferred around the hospital and his acuity. So here comes some acuity, and this is a long aliquot. So if you can't keep up, whoever's scribing, I'll put in the chat again. So upon arrival to the medical floor, the day of admission, he had worsening oxygen saturation to 90% on 6 liters of nasal cannula. So he was transferred to our step-down unit for high flow nasal cannula. A repeat chest X-ray was done. It redemonstrated stably prominent interstitial markings. They got an ultrasound of his legs that was negative for deep vein thrombosis. An echo showed normal LV systolic function, normal RV size and systolic function, and an IVC diameter less than 2.1 centimeters. He was started on Zosyn. A chart review revealed that the patient had recently been hospitalized 12 days prior for a total of 2 days prior to this admission for low volume hemoptysis. During that admission, a CT scan of the chest without contrast showed a left lower lung lobe mass that was about 2 by 2 centimeters, extensive mediastinal and left hilar adenopathy. A biopsy of the lymph node showed poorly differentiated non-small cell lung carcinoma. Regular cultures, AFB cultures and fungal cultures acquired via BAL during that biopsy showed no growth. PCR testing of the BAL specimen showed very low levels of HSV 1 and 2, no CMV or VZV detection. 2 sets of blood cultures at hospitalization were negative. Legionella and pneumococcus antigens were negative, and PCR testing for HIV, SARS-CoV-2, and RBP, respiratory viruses, was negative.
Oy, oy. Well, I think you made a lot of progress here because I think the needle is shifting towards prioritizing an intrinsic lung issue over the heart. And I think the most powerful data point is the fact that the patient's there are two powerful data points: the worsening hypoxemia despite a stable X-ray, and then I think the fact that the cardiac filling pressure seemed to be normal, as inferred by the size of the IVC. So I think you haven't exonerated the heart, but you've tempered your enthusiasm that diuretics are going to fix this problem, especially when you found a lung problem, and that lung problem on the prior hospitalization seems to be lung carcinoma. And now that we know that he has had a history of this, and I think that the question is there disease recurrence or disease progression? But no matter what, I think now this is a progressive hypoxemia in the context of a patient having a new diagnosis of lung cancer. And I'd say the most common cause remains not related, not a cancer, not a direct consequence of the cancer, but rather as a result of the immunosuppression, anatomically or otherwise, and causing a post-obstructive pneumonia. So I think a CT scan here would be very helpful to delineate that possibility. But the range of possibilities that we could map onto a new or worsening diagnosis of cancer and dyspnea is ridiculously extensive. It sheds the spotlight on the pleural disease process that we talked about, diffuse parenchymal involvement either as mass-like lesions or lymphangitic carcinomatosis. And then also, given the disconnect between the chest X-ray findings and the hypoxemia, wondering whether there's a vascular dimension to this case, either through PE or through rapidly progressive pulmonary hypertension. So those are just the millions of ways the lungs can be involved, as the hypoxemia can worsen in the setting of a new diagnosis of lung cancer. The most feared cardiac consequences, again, we've partially exonerated the heart, not fully, are malignant pericardial effusion. So I think that you have to really think about in this patient. And then less commonly, because we said endocarditis earlier, merantic endocarditis or cancer-associated endocarditis would be a nice way of connecting the liver and the renal involvement in terms of either heart failure or embolic disease. But I think what this patient really needs now is a repeat of that CT scan to get some clarity on what's going on. And I think the fundamental problem is inflammation, hypoxemia that's worsening, a reduction in the probability of heart failure causing it, and an increase in probability of there being a lung issue. And let's hold on to the facts that this patient is immunosuppressed, has not fully explained liver, kidney issues, and now has a new diagnosis of worsening lung cancer. So the mental gymnastics to get to the bottom of this in real life are literally impossible. You can imagine this patient has 17 consultants thinking about him. So we'll slowly start to lean on the more than 17 people here in the chat to start to make some progress. All right, Andrew, tell us more.
Yeah, given how sick he was and how rapidly he went from the ED to step down to ICU when I actually intercepted him, it was very hard to figure out which of these tests were going to get done first. And the logistics of this case were very complicated for sure. I know typically it's supposed to be 5 aliquots. I'll do 2 more because it's still pretty early. So this is the CT scan you wanted. A new CT scan of the chest without contrast showed interval increase in the size of the recently visualized left lower lobe lung mass to 2.7 to 2.3 centimeters. It showed diffuse ground glass opacities, perilymphatic hyperdensities, and increased mediastinal lymphadenopathy. The following day, which was day 3 of admission, he was intubated for worsening hypoxemia, increased work of breathing, and altered mental status despite aggressive IV diuresis. He was started on norepinephrine for shock. A CT scan of the abdomen and pelvis without contrast showed new nodularity throughout the abdomen and retroperitoneum, small volume ascites, and interval increase in bilateral adrenal thickening.
Yeah, well, I mean, I think that like the tempo at which this patient is getting ill is very concerning. And I think he has a malignancy, and now you're wondering, is this malignancy just taken off and gone somewhere all to all these places? which is not the typical behavior pattern, but if you extend the fact that, things exist up to 2 standard deviations beyond the norm, this is certainly well described, especially with adenocarcinoma taking off so quickly. And so the question is there any reason to not proceed with the hypothesis that this patient has had progressive severe lung cancer? And the answer is simply because there might be a possibility driven by his immunosuppression that he has 2 issues, both a disseminated malignancy and maybe a disseminated immunosuppression related infectious process. And the latter is reversible to some extent. So you have to think about that. And I think the most powerful thing is that he has perilymphatic, one of the most powerful things is he has perilymphatic hyperdensities. That can definitely be consistent with lymphangitic spread of his tumor, but also maybe potentially evocative of a lymphotropic infection like TB and histoplasmosis and the rest of the endemic mycoses. So all of a sudden, the patient's epidemiological exposure becomes really, really important. And scrutinizing all that, the culture data that Andrew gave us becomes even more important, and wondering whether we should acquire that again. It's very easy to lose track of the fact that this patient is not just hypoxemic, but in shock, and wondering why there has been, in addition to respiratory collapse, cardiovascular collapse is really, really important too. And the mechanism might be that there's understanding the mechanism of that through many, many tools, but also the mixed venous oxygen saturation can help you figure out if it's primarily septic or cardiogenic, which I think would be the two, septic, cardiogenic, or obstructive would be the 2 leading categories. And new nodularity in the abdomen and the retroperitoneum again just reinforced the idea that it might be a pretty bad metastatic cancerous process or a disseminated granulomatous infection. Both of those are totally fair game. And the question is, well, what can you do with the bilateral adrenal thickening? And thickening is an interesting word. Whenever you hear the word adrenal in the context of a very sick patient, especially one who's in shock, you have to wonder, are they adrenally insufficient and steroids are needed to help them? You also might wonder the exact opposite hypothesis, which is that there's adrenal enlargement or thickening, and that's causing an adrenal Cushing's syndrome, and that's causing the immunosuppression that this patient is dealing with. And the intriguing relationship between Cushing's and the immune system is that patients with Cushing's disease Cushing's syndrome definitely get a whole variety of atypical infections, including nocardia and TB and histo. And they also actually, the immunosuppressive effects of steroids can also promote cancer formation. And we know that because adrenal carcinoma itself promotes its growth. It's a really interesting fact. Adrenal cortical carcinoma secretes in some fraction ACTH, which goes on to produce cortisol, which further allows the tumor to grow. So you might conjecture, hey, is Cushing's going on here in this patient? Is immunosuppressed or is allowing the cancer to grow? The list of infections that go to the adrenal gland again are primarily TB, histoplasmosis, with rare mention of CMV and HIV. And in this immunosuppressed host, I think CMV is definitely something to think about, particularly given the ground glass opacities. So, gosh, I mean, how do you make progress here? I think it's very, very tricky. You probably are worried that this represents a very aggressive cancer that's taking off, but open to the possibility that a granulomatous infection may be contributing here. And then the only additional things are wondering, is this patient having a disseminated CMV syndrome with the GGOs in the lungs and the adrenal findings? Really, really tricky to make confident progress. So if I were taking care of this patient in real life, I think it is a monumentous task to continue to provide supportive care for the patient, let alone know how to make diagnostic progress. Tricky, really, really tricky, Andrew.
Yeah, more on that at the end for sure, but very hard to be confident in a case like this. That was our experience in working and managing this patient. So this is the last aliquot. After initial stabilization via mechanical ventilation and vasopressors, an ERCP was performed. It showed no biliary stones or filling defects. Dialysis was initiated for progressive kidney failure. A repeat bronchoscopy was pursued, and that redemonstrated a negative infectious workup for routine bacteria, AFB bacteria, and fungi. He received Zosyn for 8 days, Doxy for 6 days, Bactrim for 3 days, and voriconazole for 2 days. He unfortunately had 4 days of increasing vasopressor requirements, despite all of these antibiotics and stress dose steroids. So goals of care were transitioned to comfort measures at that point, and an autopsy was performed. And then the final diagnosis was found.
Yeah. Oh gosh. I'm gonna slow down here and just lean on you guys. So please, we're very good on time. Um, I'm giggling a little bit because Reza accuses me of babbling. I wish you were here to see us at 9:30. I've talked so much. I'm gonna make him watch this VMR. Anyway, tragic outcome for the patient. I'm shocked that with the 12 days of progressive shortness of breath that this patient has unfortunately succumbed to this disease. Yeah, put your thoughts in the chat and I will share mine in a second. I don't have any guiding questions, by the way, which was normally actually a much better facilitation tool because this, I don't know what the, I cannot guide you because I am utterly clueless myself. All right, let's just learn from Andrew. I'll say that um, this is the signature of a the making a lot of inferences here and a lot of guesses. The signature of this disease process is very much in line with a very bad cancer, and that radiographic pattern of lymphangitic spread, peritoneal nodularity, in a patient who doesn't have prominent epidemiological risk factors for TB or the endemic mycoses, especially a patient for whom you have a biopsy that says cancer, and for whom you have a really aggressive infectious disease approach, cultural wise, and also in terms of empiric treatment for many infectious diseases. So the question is, in my mind, I believe I lean into the possibility that he has a malignancy. I'm just not sure what that is. And I think the reason I'm not sure what that is because the biliary dimensions of this case are very intriguing to me. And I'm also applying the filter of rapidly progressive tumors in a patient who has had a liver transplant, is having biliary strictures, has Hep C, and wondering if we might have had the tumor wrong, which would be a very rare situation. But what cancers can be this aggressive? I think a liquid tumor showing up as an adenocarcinoma, or hey, Andrew, can you remind me actually what was the pathfinding at the other facility in terms of the cancer?
Yeah, so the recent biopsy was non-small cell lung carcinoma.
Gotcha.
And then
Yeah.
he had a lung adenocarcinoma on the other side, which I actually didn't provide that detail earlier, and that was years prior. And I actually don't have the details on when exactly that past medical lung adenocarcinoma was.
Yeah, I'm wondering, like if you ask yourself, what are the tumors that can be this aggressive? I think small cell carcinoma would certainly be this aggressive, and I'm wondering if the directly from the beginning was a disease occluded the disease process to another disease process, namely cholangiocarcinoma. That can be very, very aggressive, and especially with its propensity towards to the abdomen. So I have no confidence about what's going on. I think an autoimmune disease is extremely unlikely. I think an occult infection would have us reflecting really hard on this case and would be humbling and would be a massive learning exercise for me. I think that there are many tumors that can be aggressive. This aggressive, they're often liquid tumors. A solid tumor that could have gone undetected and potentially mischaracterized, might have been a cholangiocarcinoma. And the risk factors for that are his biliary strictures and his cirrhosis. But I'm really curious to learn what from this case, and it's definitely at my growth point. Enlighten us.
Yeah, yeah, of course. I think the liver disease did make this especially complicated because we weren't really sure how much focus to put down there. And of course, he ultimately did get the ERCP, but after he had been stabilized. So this is the diagnosis, and then some comments before the teaching points. So he had the autopsy, and it revealed metastatic thoracic undifferentiated carcinoma that was specifically SMARCA4 deficient. I actually still have to read about that a bit more, but that basically makes tumor very, very, very metastatic and malignant. And this was complicated by lymphangitic carcinomatosis, and the findings in the belly were the same exact thing. The adrenal thickening was the same exact thing as well. So some quick comments on kind of the real life journey, because this all happened so quickly. My chief, Dr. Alex Hurd, was actually involved in the step down care of this patient. And when I inherited this patient, he was saying that at the time we already knew about the lymphangitic carcinomatosis, or rather findings on the CT scan that could be consistent. It actually wasn't read as lymphangitic carcinomatosis, but with the recent biopsy on chart review done showing the lung cancer and that CT finding, he felt pretty strongly that this could be consistent with a very rapidly progressive cancer. And to me, that was completely new. Coming out of med school, I only thought of cancer really as a chronic, occult progressive disease, but this totally changed the way how I view that, and that some cancers can be so malignant and aggressive like this. So some comments on kind of hypoxemia and cancer and end-stage manifestations of cancer in the lungs. There are really two entities that I'll review really quick. There's pulmonary tumor embolism and lymphangitic carcinomatosis. So first, pulmonary tumor embolism. That refers to the identification of tumor within pulmonary arteries and or capillaries, whereas lymphangitic carcinomatosis refers to identification of tumor in lymphatic vessels. The syndromes commonly overlap and are end-stage manifestations, as I said, of malignancy. The majority of patients with these conditions present with subacute, progressive, unexplained dyspnea. Traditionally, it is thought that pulmonary tumor embolism is more likely to present with features of pulmonary hypertension or venous thromboembolism, and notably a normal chest X-ray. On the other hand, lymphangitic carcinomatosis is more likely to present with interstitial infiltrates on chest imaging, as in this patient. Diagnosis is often not made until autopsy. It requires biopsy in order to make, really. It should be suspected in patients with suspected cancer, progressive hypoxemia, and initial workup negative for PE or pulmonary hypertension. And really for diagnosis, I referred to biopsy, but in terms of like approaching this diagnosis, it's very tricky given kind of how invasive the testing is. And also goals of care definitely plays into this. So other than lung biopsy, tests are nonspecific. Chest CTA, VQ scan, and echo can be used to raise suspicion, and prompt testing via transbronchial biopsy, or you can even use like a right heart cath, Swan-Ganz cath, to sample the PA blood for tumor. That would kind of be your surrogate for identifying tumor within the pulmonary arterial vasculature. So based on goals of care, I think some of that testing can be pursued. That actually was brought up by our chief, but not ultimately pursued. So that's all I got. Really, really tough case. I definitely brought all the teaching points with me beyond. I've seen several other patients with cancer, unfortunately, present quite rapidly since, and I think it's just because I'm primed to kind of see that now. But yeah, I'm curious for everyone else's thoughts.
Andrew, this is an incredibly educational case. I think it's so tragic. Like if you really step back and think about what this lived experience might have been like to accumulate this degree of medical problems and to get a transplant and to be on immunosuppression and then to have presumably very rare, but maybe immunosuppression related, I'll have to read about it, malignancy. It's just so devastating. And I think, I think the attention to detail to pick up on the subtle clues that help you put this case together. I think it is understated how when you hear that somebody has cancer and you hear they're hypoxemic to prioritize infection, but attention to the subtleties on the radiology. A lymphangitic pattern is very suggestive of metastatic cancer spread. But you have to take a breath and say, hey, I know other things like lymph nodes, and I have to make sure that those aren't happening. And I think clearly due diligence was done. And I love your commitment to learning and growth, emphasizing in this case the more simple stuff, starting off by letting us learn about hypoxemia and chest pain and dyspnea, and then the exam, and just how you presented this case in a manner that allowed us to touch on the common and then definitely the not so common. So really, really appreciate you. Thank you very, very much. I'm gonna try to put together a video for the RLRCP Solvers website of cancer and dyspnea, prompted by this case. I just wanted to show you a quick visual of just how complicated, like how extensive this space is and how much work you have to do. It's in many ways driven by common things, but here, take a glance at how big this list is. These are just cancer unique causes, let alone just having somebody having shortness of breath independent of their dyspnea. It's a lot of things. So I really appreciate you pushing me to learn more, and I'll definitely have to read about this cancer. I've never heard about it before. Since we have a few extra minutes, I'm curious to see if anybody in the chat has questions before we summarize the learning from Andrew's excellent case.
Hey Jane, I just saw your question. I wasn't so sure about that. Yeah, I don't really know how to explain that, especially with the IVC diameter being on the lower side, and the imaging was, I guess the ground glass could be edema. But yeah, I'm not so sure about how the BNP was so up on initial presentation.
Great question, Jane, and thank you so much for the kind words, Eric. Well, if all you don't know, we are joined by the Eric Strong who is an incredible educator on YouTube. Maybe I actually will take a minute, Eric, to put in your channel in here for those people who may not have heard your work, but I suspect they're a small minority. Other thoughts or questions?
I'm not sure what could have been done earlier if this was detected earlier. From oncology, I feel like I hear cancers that can be treated, like acutely in patients who are on a vent and on pressors is small cell. That's the one I can think of. This, I don't get the sense that this is one that you can kind of treat acutely and kind of survive.
Andrew, I actually had another question about lymphangitic carcinomatosis. I'm wondering in your reading if you came upon any of the epidemiology, like who was this common in, risk factors, things like that.
Yeah, all I know is it's actually quite rare for tumors. At least less than 5%. I think it's more on the order of like 2% of people actually develop this complication. So it's actually quite rare. And the illness script, again, I think is kind of people with consistent imaging and the subacute progressive nature presentation that doesn't improve with diuresis and antibiotics.
Thank you. Really an amazing case.
In my intern year when I had this patient, it was really challenging, to be frank, because he was quite well leading up to the recent hospitalization. And even after that, he had COPD, so they didn't really think too much of the dyspnea. So this really, as an art end, came out of nowhere for the family and the patient. So this was very, very hard in terms of transitioning care. We really had to do everything to show that, prove that this was essentially like a diagnosis of exclusion. And even then we weren't sure. So it was very hard.
I would say I'd encourage you. There's so much learning in this case, and I think I'll just share some learning strategies. When you're trying to reflect on a case like this, it's easy to actually not make any progress in terms of your clinical reasoning because it's so overwhelming. It's literally drinking from a fire hose where you end up actually absorbing nothing. So my advice for you is before you leave this call to ask yourself, what's the one thing or two things that you're going to retain from this? And for me, I think I'm going to practice my cancer plus dyspnea framework that I just outlined. And then I want to read for 20 to 30 minutes about this cancer. I don't think I can read more about it because that return on investment may not be super high, but just to know a little bit about it to maybe think about it a few seconds earlier than I would have today. All right, y'all. Thanks for hanging out, but we'll go through the journey again and one more time with our very own Mukund to go through the teaching points.
Sure. I think what you said at the very end is really the key takeaway for me, is that usually I like format these teaching points and I have little bolds and underlines and I'm able to sort stuff into buckets. And this time I just kind of gave up on that halfway through because we were going all over the place and covering so many different disparate things because there was just so much going on with this patient. For me, I think my personal takeaway is really going to be learning a little more about how cancer can present on chest imaging. There was so much that you managed to pull out of descriptions of imaging findings that I don't think that I could have come to on my own. So that's going to be my personal takeaway. And I love the suggestion to compartmentalize and choose one of these many things to learn more about. I'm going to go through what I have on here. I didn't get everything, but here we go. We started off with this, relatively innocent complaint of progressive dyspnea and chest pain, but which was complicated pretty immediately by an extensive past medical history and immunosuppressive medication. So we started framing this case by saying that multiple organ systems are down, including the lung from COPD, the liver from cirrhosis, the kidney from chronic kidney disease, and the immune system from the medications he's taking. And this is another great learning point for me personally, is what happens to people who are on immunosuppressive medications at different stages of their treatment, subacutely, chronically? What happens to their labs? What happens to their ability to respond to different kinds of infection, their predisposition for malignancy? That's another great set of teaching points. I wish that I could go through with you, but I'm going to have to go through on my own and learn first. There's the background. We moved on to a foreground, a more acute foreground of hypoxemia plus chest pain. And we got a great pearl that many of the cases of chest pain that you see in isolation are benign and are discharged without intervention. But chest pain plus other symptoms, especially chest pain plus hypoxemia, confirms a more sinister etiology. We went on to talk about the fever that this person is having. And aside from infection, went over the 3 H causes of fever that we really need to be paying attention to in the first hour, including hyperthyroidism, hematologic causes, especially febrile non-hemolytic transfusion reactions, and hyperthermia, including from serotonin syndrome, neuroleptic malignant syndrome, malignant hyperthermia, none of which we considered really being the case for this patient. We also talked about how febrile primary cardiac disease is unusual, although we have a hypoxemia and chest pain situation that makes us think, oh, maybe the heart's involved, with the only kind of 3 febrile cardiac diseases being endocarditis, myocarditis, and pericarditis. We also talked about fever and new heart failure symptoms leading to a check of TSH to rule out thyrotoxicosis. And given this person's biliary history, fever, cholestasis, and direct bilirubinemia should mean cholangitis until proven otherwise. At this point, we got a whole bunch more information. We got this set of aliquots about non-small cell lung cancer on biopsy. And we started talking about cancer and primary pulmonary diseases as being the center of gravity. We learned that paralymphatic hyperdensities are most consistent with lymphatic spread of malignancy, which we'll get to in a bit, but also could involve infectious spread. And in this patient who's immunocompromised, to consider a simultaneous co-occurrence of malignancy and infection. We talked about the adrenal thickening, which was found on imaging as either a potential adrenal insufficiency or potentially a hyperplasia leading to Cushing's syndrome, and that presentation causing its own kind of immunosuppression, and one that is associated with aggressive malignancy. We brought back infections again, talked about TB, histo, CMV, and HIV as involving the adrenal gland. We continued onward to talk about potentials for aggressive malignancies that this person was facing. We came up with cholangiocarcinoma as a possibility, given his risk factors of liver disease and biliary strictures. But in the end, we identified a diagnosis of SMARCA4 deficient thoracic undifferentiated carcinoma, super aggressive. I love these teaching points. Went and looked up SMARCA4. Turns out it's a tumor suppressor gene and that its absence is associated with really aggressive types of cancer, but it's a pretty rare mutation. And then finally, we learned about the contrast between two kinds of complications of aggressive metastatic cancer, one being lymphangitic carcinomatosis with tumor identified in lymphatics, and the other being pulmonary tumor embolism, where tumors identified in systemic circulation and where emboli end up in the pulmonary vasculature. So yeah, I did my best. There was a ton going on in here, and it was a pleasure for me to be with you today.
Well, the pleasure's all ours. I don't know if it's anything shorter than a masterclass to dissect all that and to organize it and to present it as clearly and deliberately as you just did. And I think I will just say for the people who are still here that you will finally get to see Mukund in discussing action to heap the pressure on him next Thursday. So please make it a priority to come and show him some love as he discusses his first case next Thursday. Anyway, a treat to have you all here. Thank you, Andrew. Thank you, Maddie, for scribing and Mukund for the teaching points. And we'll see you guys next time. Bye.